Hello anatomy students, welcome to the first of 4 videos that will address the digestive system. Each time we eat a meal and drink fluids, our bodies take in the nutrients necessary for survival. However, these nutrients must be digested and processed, broken down both mechanically and chemically into components small enough for our cells to use. These components are absorbed from the digestive system into the bloodstream and transported to the body tissues. After the nutrients from foods are absorbed, some materials remain that cannot be digested or absorbed, such as cellulose and fiber. These materials must be expelled from the body through a process called defecation. All of these functions are the responsibility of the digestive system. Let's talk about the digestive processes. First, you have to ingest something. This is the introduction of a solid or liquid material into your oral cavity. It is the first step in the process of digesting and absorbing nutrients. The digestive system, of course, includes the organs that ingest the food, transport the ingested material, digest the material into smaller usable components, absorb the necessary digested nutrients into the bloodstream, and expel the waste products from the body. Let's start with the ingestion process again. When you eat, when you put food into your mouth and it mixes with saliva as you chew, that chewed food mixed with saliva is now called a bolus. And it is the bolus that is swallowed. The stomach then will process the bolus and turns it into a paste-like substance called chyme. Hereafter, if I'm talking about a substance after the stomach, say in the small intestine, I'm going to refer to it as chyme. Once the chyme passes from the small intestine into the large intestine, this now is referred to as fecal material. The action of digestion itself is the breakdown of large food items into smaller structures. There are 2 aspects to this: mechanical digestion, which means the physical breakdown of ingested materials into smaller pieces. And hey, most of us think mechanical digestion is only chewing in your mouth, and that's not true. We're going to see mechanical digestion, as shown on this slide, occurring in the stomach through churning. And we can also see the small intestine participating in this with segmentation. Chemical digestion involves the breakdown of material into smaller molecules. Chemical digestion means we have enzymes that are breaking large macromolecules into their components, and this is necessary for you to absorb these small components across your mucosal membrane. After the materials are swallowed, of course, they need to be propelled through the GI tract. There are many types of movement available depending on where you are. Your book lists peristalsis and segmentation as 2 major types of movement, and I will talk about the types of movement propulsion that are possible depending on where you are in the alimentary canal or digestive canal. We also need secretion of these chemical enzymes that I told you about. The chemical enzymes are going to take macromolecules and reduce them down into their monomers, their components. For example, protein is a macromolecule, and digestive enzymes are going to hydrolyze the bonds in between individual amino acids. The individual amino acids are the monomers, or the components that make up that macromolecule we call protein. We're going to see digestive enzymes released beginning with the mouth, continued with the stomach, and a huge amount of digestive enzymes released by the pancreas and the small intestine. Absorption occurs through your membrane transport mechanisms. Look, we've learned this from Unit 1. You remember them as passive transport or active transport. We think of diffusion, facilitated diffusion, etc. All types of membrane transport help absorb your nutrients, and the water follows them from your gut into the bloodstream. The final function of your digestive system is to eliminate waste, the parts of your food that you could not absorb. We also have some accessory organs that are going to release waste components from red blood cell turnover, like bilirubin, into your feces. So all of the undigestible materials, as well as the waste products secreted by the accessory organs into the GI tract, are going to become compacted into feces. And the fecal material will then be eliminated from the GI tract by the process of defecation. The digestive system is composed of two separate categories of organs: digestive organs and accessory digestive organs. The digestive organs collectively make up the GI tract, also called the digestive tract or alimentary canal. The digestive organs are the oral cavity, the pharynx, esophagus, stomach, small intestine, and large intestine. These organs form a continuous tube from the mouth to the anus. Accessory digestive organs are not part of the long GI tube proper, but they often develop as outgrowths from the proper tube and are connected to this GI tract. The accessory digestive organs assist the GI tract in the digestion of material, and these accessory organs include teeth, the tongue, salivary glands, liver, gallbladder, and the pancreas. Let's take a quick review of the mouth. Let's first address the lips and the cheeks. Remember from Lab Unit 2, when we learned about skeletal muscle, we learned about the buccinator muscles. These are the muscles that form your cheeks, and the orbicularis oris, which was the skeletal muscle that surrounded your lips. The buccinator muscles, of course, allowed for your cheek compression, and this helps keep the bolus of food in the middle of your oral cavity. And the orbicularis oris, of course, when it contracts, it closes your mouth. Your entire mouth is lined with stratified squamous epithelium. Your textbook goes to great lengths to describe whether or not it's keratinized in this place or that place versus non-keratinized. I don't care about keratinized versus non-keratinized. I worry about the stratified squamous epithelium and you understanding why it is stratified squamous epithelium. What types of protection does this kind of epithelium afford you? Of course, we think of the mouth as a place where there's a lot of mechanical breakdown, a lot of abrasion from the food that we eat, and even the very acidic environment from our saliva. I shouldn't say very acidic, but it is still acidic. So the stratified squamous epithelium, of course, is going to provide a large barrier to withstand abrasion, and it also has a high turnover rate to regenerate new cells. Let's take a survey of the anatomy of the mouth. If you were to close your mouth, clench your teeth together, believe it or not, there is a space anterior of your teeth but posterior of your lips. Now open your mouth just slightly and rub your tongue along the anterior surface of your upper teeth. And you're feeling that pocket-like space between your lips and your teeth. That space is called the vestibule. Of course, there's also a vestibule with the lower lips, too. Now let's talk about the labial frenulum. If you put your tongue back on the surface of your teeth, the anterior surface, and along your upper gum line, your gingiva, you might feel that little string-like attachment shown in this picture called the superior labial frenulum, and there's also one called the inferior labial frenulum. And this is where the superior and inferior lips are attached to the gingivae by a thin mucosa fold in the midline. Now I want you to lift up your tongue, or have your tongue lift up superiorly to hit the top or the roof of your mouth. And if you could look in the mirror or even feel with your finger you can feel that there is also an attachment for your tongue to the base of the mouth. That's called your lingual frenulum. Sometimes babies are born with a very thick lingual frenulum, or should say short lingual frenulum, and they can't move their tongue around as well. And so when they talk, because they can't move their tongue, try and talk without being able to move your tongue. Try and talk without being able to move your tongue. You sound a little funny. You sort of sound like Barbara Walters, or Baba Wawa, as I like to say. Now, I'm not saying she speaks that way because she has a short lingual frenulum, but when a child is born with a short one, it simply is a matter of snipping it and letting it heal, and it will elongate. Now let's continue with the palates. This is a review. Of course, we know that there's a hard palate and a soft palate. The palate forms the roof of the oral cavity and acts as a barrier to separate it from the nasal cavity. The anterior 2/3, as we learned from our lab unit 1 when we learned about bones, the anterior 2/3 of the palate is hard and bony, and it's called the hard palate, whereas the posterior 1/3 of your palate is soft and muscular, and this is called the soft palate. Let's review. The hard palate is formed by the palatine processes of the maxillae and the horizontal plates of the palatine bones. The soft palate is continuous posteriorly with the uvula, and when you swallow, the soft palate and the uvula elevate to close off the posterior entrance into the nasopharynx and prevent your food from entering the nasal region, or as I like to say, you don't want to blow your food out your nose. Now, if you look at the back of your mouth, you see fauces. Fauces represent the opening between the oral cavity and the oropharynx. I like to think of them as the tunnels to the back of your throat. The fauces are bounded by paired muscular folds shown here in this picture. The palatoglossal arch is the more anterior fold, and the palatopharyngeal arch is the more posterior fold. And between these two, we find the palatine tonsils. And remember, these tonsils are a blind pouch of mucosa-associated lymphoid tissue. We learned this back with our lymphatic system. And here, this mucosa-associated lymphoid tissue with lots of T cells and B cells is an early line of defense. They monitor your ingested food and drink for antigens and initiate an immune response when necessary. Let's now talk about the surface of your tongue. Perhaps you've noticed maybe when a cat or a dog is licking you that their tongue sort of feels rough, right? Well, this is from papillae that are on the surface of the tongue. A lot of this information regarding the papillae is actually not in your digestive system. Rather, it's found in your general and special senses chapter of your textbook. So let's just start with the surface of the tongue and the purpose of the tongue. The tongue, in addition to helping with sound production, as you just learned with the lingual frenulum, helps manipulate and mix ingested materials during chewing, and helps compress the materials against the palate to turn them into a bolus. The tongue also performs the initial acts for swallowing, and the tongue attaches to the floor of the oral cavity, as you learned, by a thin vertical mucous membrane called the lingual frenulum. In addition, the posterior surface of the tongue also contains lingual tonsils that are comprised of mucosal associated lymphoid tissue. The tongue, of course, is considered to be an accessory organ. Now let's talk about these different papillae. On the surface of the tongue you have papillae, and that means small nipples. Weird to think of small nipples on the surface of your tongue, but that's what the word means. There are 4 types of papillae: filiform, fungiform, valate, and foliate. The filiform papillae are the most numerous. They are short and bristle-like. They are distributed on the anterior 2/3 of the tongue surface. They do not have taste buds. Their role is mainly to be a way of gripping the food and the bolus and moving it around. So they're your gripping papillae. Fungiform papillae are block-like projections primarily located on the tip and sides of the tongue. And they do have a few taste buds. And look, when you get back to class and we start to do the histology of the alimentary canal, I will show you a slide of a papilla, a fungiform papilla or velate papilla. You can actually see these taste buds on the sides of the papillae. Okay, the fungiform, like I said, are block-like. They do have taste buds. And then the velate papillae, or sometimes called circumvallate papillae, are the least numerous, but they are the largest papillae. And they are arranged in an inverted V-like shape on the posterior side of your tongue. And the border that you're seeing there between the tongue, that inverted V-like shape, in between the velate papillae and the root of the tongue, that space is called the sulcus terminalis. The velate papillae have a lot of taste buds on the walls of these but the velate papillae, lots of taste buds, as shown in the top right picture. Now, your book lists foliate papillae, but they are not very well developed, and they're mostly important for infancy and early childhood. Each cylindrical taste bud, by the way, is composed of numerous taste receptors called gustatory cells. And the gustatory cells within the taste buds are specialized neuroepithelial cells, and they only have a lifespan of about 7 to 10 days. And they repopulate from stem cells called basal cells. Beginning at about age 50, our ability to distinguish between different tastes declines because we lose our gustatory cell replacement and the number of taste buds. Thus, an elderly person can complain that food is tasteless or very bland. It also takes time for taste buds to develop, and it's really true with young children that they might not like something this week, but give them a little time to develop, maybe a few months, and they might acquire a taste for something. It's because of those taste buds trying to develop. Medicines can also affect your taste buds. Antibiotics, for an example, sometimes the antibiotics we might be on let us have kind of a metallic taste to the food that we're eating. Don't worry, give it time. Once the antibiotics when you're done with that course of treatment and your taste buds replace within 7 to 10 days after finishing your treatment, your sense of taste will come back to you. The salivary glands collectively produce and secrete saliva, a fluid that assists in the initial activities of digestion. We make an average volume of saliva somewhere near 800 milliliters through 1.5 liters a day. Additionally, if you did not make this amount of saliva, which consists of water, ions, mucus, and even enzymes that help with digestion, but they also serve as an antibacterial fluid. For example, saliva contains antibodies and antibacterial substances that will inhibit bacterial growth in the oral cavity. If you do not make enough within 24 hours, you can have more sores in your mouth. You can even have more dental caries or cavities in your mouth. Do you take an antihistamine regularly? If you do, this inhibits your saliva production. You should see your dentist more often because a side effect of that antihistamine use is going to likely be more mouth sores and cavities. Most of your saliva is formed from your extrinsic salivary glands. These consist of the parotid glands, submandibular, and sublingual glands. The parotid salivary glands are the largest of the three. Each parotid gland is located anterior and slightly inferior to your ear, and it partially overlies the masseter muscle. The parotid salivary glands produce about 25 to 30% of your total saliva, and this is secreted through the parotid duct, and the parotid duct extends from the gland. It goes parallel to the zygomatic arch before penetrating the buccinator muscle and opening into the vestibule of your mouth. Remember, that's the space between your cheeks, or lips and the anterior surface of your teeth. So it inserts into the vestibule of the oral cavity near your second upper molar. Continuing on, as their name suggests, the submandibular salivary glands are inferior to the body of the mandible. They produce most of the saliva, about 60 to 70%. A submandibular duct transports saliva from each gland through a papilla in the floor of the mouth on the lateral sides of the lingual frenulum. The sublingual salivary glands are inferior to the tongue and internal to the oral cavity mucosa. Each sublingual salivary gland extends multiple tiny ducts that open into the inferior surface of the oral cavity, posterior to the submandibular duct papilla. They only contribute about 3 to 5%. When we look at these glands histologically, we try and categorize them as to do they have mostly mucus secretions or serous, which means water secretions, or a combination of both. So two types of secretory or secretory cells, it depends if you're from England or not, are housed in the salivary glands. These cells are either mucus cells or serous cells, and the mucus cells secrete mucin, which, when added with water, creates mucus. Remember, M-U-C-U-S is the noun. That's mucus, the substance. A mucus cell, that word mucus, is now used as an adjective, and it's spelled M-U-C-O-U-S. Serous cells secrete a watery fluid containing ions, lysozymes. That lysozyme helps protect you from bacteria, and salivary amylase. Salivary amylase is the enzyme that begins carbohydrate digestion. So chemical digestion begins, albeit for a short time, in your oral cavity with the digestion of carbohydrates, at least the beginning of it. The salivary glands are grouped into either being mucosal or serosal or a combination of both. The submandibular and sublingual glands produce both serous and mucus secretions. However, the sublingual gland produces slightly more mucus secretion. That's the reason why your dental hygienist likely spends a lot of time scraping your lower incisors, because that's where the sublingual ducts are opening up behind. The parotid gland, however, is considered to be mostly serosal secretions. And again, when we look at these glands histologically, if you look over here in the bottom right picture, you can see that mucosa cells stain lighter and serosal cells stain darker. I think of the mucosa cells looking light and fluffy like clouds because they're filled with mucin, a fat product. And the serosal cells have more granules in them, and they present with a darker stain. The salivary glands are primarily innervated by the parasympathetic division. In particular, the facial nerve, cranial nerve 7, innervates the submandibular and sublingual glands, whereas the glossopharyngeal nerve, cranial nerve 9, innervates the parotid gland. When parasympathetic division has more control over you, your salivary gland secretions increase, which is why your mouth waters when you are presented with a delicious dinner, maybe your Thanksgiving dinner. Your salivary glands are preparing for the start of the digestive process when you are seeing food. We certainly think of this with Pavlov's dogs, right? When he rang a bell right before dinner, their mouths would start to salivate, and eventually just ringing the bell would get them to salivate in anticipation of a meal arriving. In contrast, the sympathetic stimulation inhibits normal secretion from these glands, which is why you experience a dry mouth when you're in your fight or flight response. Let's talk about your teeth for a while here. The teeth are collectively known as the dentition, and they are responsible for mastication, the first part of the mechanical digestion process. A tooth has an exposed crown, shown here in the top right. There is a constricted neck, and there are one or more roots that anchor it into the jaw. Remember when we were learning about bones in Lab Unit 1 and we had the alveoli? Those are the little indented sockets within the alveolar processes, and these dental alveoli, the little sockets, is where the roots of the teeth will fit. Collectively, the roots, the dental alveoli, and the periodontal ligaments are going to help bind the roots to the alveolar processes, and this forms your gomphosis joint. Remember that? That's supposed to be just a slightly movable joint. Now let's talk about the cementum. The red line that I show you here on the outside border of the root, that's the cementum. Each root is ensheathed with this hardened material. And there's also a tough, durable layer of enamel that forms the crown of the tooth. Enamel is considered to be the hardest substance in the body and is composed primarily of calcium phosphate crystals. Now, what about dentin? Dentin forms the primary mass of the tooth. This is the internal area, and that's very close to the pulp cavity. Dentin is comparable to bone, but it's harder, and it is deep to the cementum and the enamel. So the enamel is going to be continuous with the cementum, if you follow this picture, and dentin is the substance deep to them. What makes dentin? Dentin is made by special cells called odontoblasts. There are ridges through the dentin, or tubules, these lined-like structures that you could see in your picture in that kind of beige area. Those are called dentinal tubules, and that helps with transport of nutrients that are coming through the blood vessels that are found here in the pulp cavity. The center of the tooth is the pulp cavity, and it contains connective tissue called pulp. There's also a root canal that opens into this connective tissue through an opening called the apical foramen, and it's continuous with the pulp cavity. Blood vessels and nerves pass through this apical foramen and are housed in the pulp. The dentin tubules, or dentinal tubules, allow for nutrients from the blood vessels to go through those tubules to serve odontoblasts that might be more distal from the pulp cavity. Sometimes these dentinal tubules can actually get through or break through your cementum, and you might have a sensitive tooth. Do you have a tinge of pain when cold water passes over your tooth, or even air? Those are your dentinal tubules that are to blame. And yes, Sensodyne toothpaste, or toothpaste like it, help create a layer that compacts or blocks these dentinal tubules on the outside surface so that you don't have as much sensitivity. Let's talk about gingiva for a moment now, and what does that mean? Gingiva is composed of dense, irregular connective tissue, and it is also surrounded with stratified squamous epithelium. It surrounds the necks of the teeth and covers the alveolar processes. What happens when you have gingivitis? What happens is you get a cluster of bacteria between the neck of the tooth and your gingiva, and the bacteria release irritants, byproducts of their metabolism, and this causes your gingiva to start to recede away from your tooth, and this increases the pockets. We're worried about this recession, and they actually measure the recession with a little ruler when you go to the dentist. It is oftentimes recommended that if you have receding gum lines, that you brush less and focus more on flossing. The flossing will help get rid of those pockets of bacteria between your tooth and your gum line better than the actual brushing. And people typically tend to overbrush. Did you know that? if you're like me, I love chewing on my toothbrush. It feels so good, but that actually pushes away the gingiva even more from your tooth. So they recommend you not do that. It is also highly recommended that you get a mechanical toothbrush and don't push as much onto the surface of your teeth and gingivae. Just let the toothbrush do its job. Focus more on flossing. Now I'd like to focus a little bit more on your dentition, or the actual teeth. Your mouth is divided into 4 quadrants, 2 upper and 2 lower. If we just focus on your upper teeth, find the middle of your incisors. Find that gap between your 2 front teeth. Once you find that gap, now I want you to take your finger and move to the right. The first 2 teeth that you come across as you move from that center tooth gap to the right, those 2 teeth are your incisors. Then that pointy tooth that you have is a canine. And then the next 2 teeth going back into your oral cavity, those are your 2 premolars. And then you have 3 molars. Or do you? If you're like me, I only have 2 molars. My last molar has been removed. All 4 of my wisdom teeth have been removed. So if you have your wisdom teeth, you have 32 total teeth. Those are your permanent teeth. What's the difference between your permanent teeth and your deciduous teeth? Well, 2 sets of teeth obviously develop during our lifetime. When we were young, we developed 20 deciduous teeth. That means falling off. We lost our teeth, and as we went through, maybe when we were 6 years or so, we started to lose these decidual teeth, and our permanent teeth came through. Sometimes I wish that we had a 3rd set of teeth, that maybe in your 40s you lost your in-between teeth, as I would like to call them. I just think that would be so much better, and we'd have fewer dental issues as we aged. Now, as we swallow our bolus of food, it's going to enter the pharynx. Remember, the pharynx is broken down into 3 regions: nasopharynx, oropharynx, and laryngopharynx. Clearly, since we're talking about eating and the process of digestion, we will address the bolus of food moving through the oropharynx and laryngopharynx. When you swallow, the uvula should raise upwards so the bolus of food cannot shoot out through your nasal cavity. Additionally, muscles of the larynx will contract and elevate the larynx, and this causes the epiglottis, one of the larynx cartilages, to bend down and block the entrance into the larynx. This will ensure that the bolus of food continues posteriorly through the laryngopharynx and into your esophagus. Both regions of the pharynx, oropharynx and laryngopharynx, where food passes by, is lined with stratified squamous epithelium to prevent any physical abrasion. Now we continue on into the peritoneal cavity and the peritoneum. I don't necessarily agree with your textbook in placing it here at this point in the chapter, but I'm trying to follow your chapter. Eventually, the bolus of food is going to travel through the esophagus, which I have yet to discuss, and reach your stomach. Of course, your stomach is a viscera found in your peritoneal cavity. Let's talk about the membranes that are wrapped around your peritoneal cavity viscerae. The abdominal pelvic cavity is lined with moist serous membranes, which we've learned from lecture unit 1. The portion of the serous membrane that lines the inside surface of the body is called the parietal peritoneum. The portion of the serous membrane that folds back to cover the surface of the internal organs or viscerae is called the visceral peritoneum. Between these 2 layers is the peritoneal cavity, a potential slit-like space where the peritoneal layers that face each other will secrete their lubricating serosal fluid. The thin layer of fluid in the peritoneal cavity lubricates both the body wall and the internal organ surfaces, allowing the abdominal organs to move freely, and it reduces friction resulting from this movement. Some organs are behind the peritoneal cavity, and we call them retroperitoneal organs versus intraperitoneal organs. An example of a retroperitoneal organ would be your kidneys, but also your pancreas and most of the duodenum. There are also long extensions of the peritoneal membranes. There are long extensions, and they can even fold over on each other, forming a double layer of peritoneum. These are mesenteries. Mesenteries, again, are folds of peritoneum, and they support and stabilize the intraperitoneal GI tract organs. They also attach them to either the dorsal or ventral body wall. Most of these mesenteries are dorsal mesenteries, which means they're attaching the organ to the posterior body wall. Just a few of them are ventral mesenteries. The ventral mesenteries include the falciform ligament, I'll explain that soon, and the lesser omentum. Dorsal mesenteries include the greater omentum, mesentery proper, transverse mesocolon, and the sigmoid mesocolon. The greater omentum extends inferiorly like an apron from the greater curvature of the stomach and covers most of the abdominal organs. Many of you in class, when we opened up the cats for our vessel dissection, asked what that layer of fat was. It looked like an apron of fat. I said that's the greater omentum. It does accumulate a large amount of adipose tissue. The lesser omentum connects the lesser curvature of the stomach and the proximal end of the duodenum to the liver. It looks like just a thin layer of saran wrap. Most of this was damaged when we were dissecting out the celiac trunk and hepatic arteries from it. The mesentery proper is a fan-shaped fold of peritoneum that suspends most of the small intestine from the internal surface of the posterior abdominal wall. Then we also have a mesocolon, and the mesocolon is going to be named for the parts of the large intestine that it anchors into. For example, transverse mesocolon is associated with the transverse colon, whereas the sigmoid mesocolon is associated with the sigmoid colon. We do have models that show these different types of mesenteries, and they can also be tagged, many of them, on the cat. For example, the falciform ligament is definitely a mesentery you should look for to be tagged on the cat. It anchors the anterior surface of the liver to the abdominal wall. We also can tag the greater omentum on the cat, the mesentery proper, as well as frequently tagged on the cat. Lesser omentum, no, not tagged on the cat. It's usually destroyed, and we don't have models that show it, though questions can be asked about it. Transverse mesocolon and sigmoid mesocolon, we do have models that represent these, and you should look at them. On this picture, you are seeing the different types of mesenteries. Of particular focus is the greater omentum, that apron-like layer of double peritoneum with a lot of adipose tissue trapped inside of it. And then on the right picture, you're seeing the mesentery proper, the fan-like mesentery that anchors all of the small intestine. I'm fairly certain you saw that on your cats when we were doing the vessel dissection. And then also shown here, you can see a section of the transverse colon, part of the large intestine. You could see that it's anchored posteriorly to the posterior body wall by the transverse mesocolon. Not shown in these pictures are the sigmoid mesocolon. That concludes our first installment for the digestive system. Time for video number 2.